Um, so thank you everyone for joining. We have our last ROVER 2.0 session of the academic year. So thank you all for joining. We'll be doing thoracic malignancies. Reminder to everyone, when you have a question, please make sure in the chat to put all panelists and attendees. And with that, we will have each one of our speakers introduce themselves. So we'll start with Dr. Amini.
Great, thank you for having me. My name is Ari Amini. I'm a radiation oncologist at City of Hope in Los Angeles, California. I grew up in Southern California and went to residency at University of Colorado, and then started here 3.5 years ago, treat head and neck, lung, and skin cancer, and really enjoyed treating lung cancer and interacting with my colleagues here today.
I guess I'll go next because I'm in the order. I'm Puneeth Iyengar. I'm a thoracic radiation oncologist at UT Southwestern. Very happy to join this great panel, and I thank all of you for inviting me to talk about the subjects that we're going to discuss. And in particular, I'll try to educate about oligometastatic disease.
Hi everyone, I'm Kristen Higgins. I am a radiation oncologist at Emory. I've been at Emory for almost 10 years. My 10-year anniversary comes up August 1st. And I specialize in lung cancer. When I first started here, I did some head and neck and lungs similar to Aria, but my practice has really transitioned to mainly just lung cancer over the last 5 years or so. So it's great to be here and interact with you all. We're excited to talk about lung cancer.
Wonderful. Well, with that, we'll start with the first case, and we will give the mic over to Dr. Amini.
Okay, great. So I get the pleasure of doing one of my favorite subjects on stage 3 lung cancer, mostly because of how complicated it is and how much things have changed. And we'll talk a little bit about the data, but my brief interaction with stage 3 over my career was 0617 kind of came out the first Astro that I ever went to. And it was pretty much one of the biggest downers at Astro for the last 5 years, I think. I walked into the plenary session, thought there was a funeral because everybody was down that high dose didn't matter. And our field for stage 3 was over. And then fast forwarding with Pacific, I think we've had a lot of advancements, some new excitements, exciting clinical trials, figuring out how radiation works with immunotherapy. So I think our field has changed quite a bit. So I know we have a lot of residency driven, but I think this is a great field for us and for residents, and a lot of you are going to be going into academics and doing research. I think this is a great opportunity for you guys. So we can go to the next slide. Our case, we have a 52-year-old, and sorry, sometimes my fan goes crazy, so I'm going to try and close some things. So let me know if you can't hear me. We have a 52-year-old female that I treated a couple years ago now. She had a prior 60-pack year smoking history, and her workup ended up diagnosing an adenocarcinoma of the left lower lobe. It was staged at a T2A, N2, multi-station N2 disease. And her workup typically started with sort of the standard way people present: shortness of breath, coughing, was on a course of antibiotics, it got worse. And so this led to a chest x-ray, which showed this opacity in the left lung, and then followed up with a CT chest and a PET scan, which we'll go over on the next slide, that showed something suspicious. And in our practice, and most practices, when you can, we recommend staging the mediastinum. And in this case, she had an EBUS. You could also do a mediastinoscopy, but she had an EBUS, and we'll go over that as well. And to complete the staging, she had an MRI brain that was negative. We can go to the next slide. So here is a cross section of our CT scan coronal images, and she had a pretty unique this unique disease. It almost looked more like a small cell, but her left lung primary was a pretty ultracentral, touching the proximal bronchus, and she had a couple AP. She had an AP window node. She had a level 4 node as well. And so we can go to the next slide, which should be her PET scan. And so this is her PET disease, showing that left upper lobe lesion that was pretty adjacent and central, hilar lymph node. And this doesn't capture the mediastinal nodes, but she had a couple of those as well. And so we can go to the next slide. This is her biopsy, and we now do testing for everybody, molecular testing. And so she had PD-L1 testing and came back pretty, I think it was about 50% positive on her case, and this was adenocarcinoma. And so at this point, we presented her a tumor board. And so we can go to the next slide, and I think we can kind of I'll get Dr. Higgins and Dr. Iyengar's thoughts on this too, but these are our patients that we typically have many different approaches. So we can go with, a combination of induction chemotherapy, induction chemoradiation, and then surgery, or definitive chemoradiation. So this patient, given the location of her disease, our surgeons did not feel would be a good operable candidate. She would have required a pneumonectomy, possibly needing radiation and chemotherapy as well. And we'll talk about a little bit of the data, but for those patients that are requiring a pneumonectomy, we definitely don't go the route of surgery. But I'm open to hear Dr. Higgins, Dr. Iyengar, if you have any thoughts as well.
I don't think there's any chance that this is a surgical case. There's no way they're going to clear disease with limited microscopic positive or negative margins. So I think we would have done chemoradiation from the get-go.
Yeah, it looks like the tumor's encasing the pulmonary artery, so I would be surprised if the surgeons would consider any sort of surgery, but resectability is in the eye of the beholder, which is our surgeons, right?
Yeah, and I agree. Our surgeons like to say anything's resectable, but then when I clarify what that means, they say, well, 90% resectable, and then we end up going with chemoradiation. So that's what we ended up doing. And so this patient got 60 gray and 30 fractions. We can talk about dosing. I think we have a poll study, but I typically don't go past 60 gray and 30. And she got carbotaxol concurrently. And actually for her, she had, you can kind of tell on the coronal image on the bottom left there, but she had a collapsed left lower lobe that her tumor responded so well that we had to replant actually 2 times during her course of radiation treatment. So we can go to the next slide. I think we have I don't know if my poll questions didn't make it in, or are they at the end? Maybe they're at the end. But I'll keep going.
You want to just ask your question?
Sure. So the poll question, and I'm open for the panel here and definitely for the audience, is the dose of radiation. So we'll talk about 0617 a little bit and how 74 gray had a detriment in overall survival. But my poll question was on the dose of radiation. Would people typically in this situation go to 60 gray, 66 gray, 70 gray, above 70 gray, or something else?
I think we would do 60.
I would too. Yeah, 60 is my go-to dose.
Okay, great. Yeah, sometimes I know some of my colleagues will go 66 when it's safe, and I tend to be. I understand with small cells sometimes we do that, but I agree. I stick to 62. So this is my sort of my summary slide of where I think lung cancer is coming from, and that was sort of my pitch at the beginning, that it's changed quite a bit. So I don't really know what the machine is I've never seen one, but that's a cobalt machine. I'm sure the residents don't know what that is, but that's where radiation, in my opinion, it's come a long way. Stage 3 has always been curable, but not as curable as it is now, with the number of improvements that we've done from a radiation standpoint, from adjuvant maintenance standpoint with durvalumab. And so I think it's changed a lot. So that's sort of what this slide is representing, that we've got protons and randomized trial trying to show whether that's beneficial. We have IMRT. And so things have changed quite a bit. We can go to the next, and there's our 4-year overall survival. I think ASCO just presented their 5-year overall survival, which is a little bit lower, but you still have a median survival of 47 compared to, I think, 29 for placebo. So pretty nice results that we're seeing. I'll go to the next slide, and I apologize for my computer fan. But this is the brief data that I won't spend too much time on, but why we avoid pneumonectomies. So this is a classic study that I still think is important. I'm a big believer that for stage 3, chemoradiation with maintenance durvalumab is the way to go for most patients, especially with multi-station N2 disease. But this patient would definitely not have gone in surgery, partly because if they had gone in a pneumonectomy, required chemoradiation, they would have had a survival detriment. In this study, you go to the next slide, when they looked at patients randomized to chemoradiation versus chemoradiation and surgery, there was no difference. But when you really look and see where that detriment came from, it was the patients getting a pneumonectomy. So that's why classically, if we're going to be doing chemoradiation and the patient needs a pneumonectomy, we don't offer surgery. So we can go to the next slide, and hopefully I'm good at time. We can, so this is just the idea, and I won't spend too much time on this slide, but that typically if we need to push for trimodality therapy, we can. The N2 disease is a bad prognostic factor, and so these are the patients that we won't go straight into surgery, that they should get chemotherapy, sometimes even arguably chemoradiation, because it can reduce that or downstage these patients. But I will say in my practice here, we don't typically offer neoadjuvant chemoradiation followed by surgery. I'm curious if Dr. Higgins, Dr. Iyengar, you guys, if you're going the surgery route, do you offer?
So at my institution, we tend to be neoadjuvant chemotherapy people. We have multiple investigator-initiated trials that are testing different combinations of neoadjuvant approaches. I think the chemoimmunotherapy neoadjuvantly is really exciting, the data that's been coming out. And so I very rarely do neoadjuvant chemoradiation. And, sometimes if you do and you give 45 gray, you're in this conundrum of not having treated somebody to a definitive dose if they end up not clearing their mediastinum, which can be a difficult situation to be in. So at my institution, we tend to favor the neoadjuvant chemotherapy approach or chemoimmunotherapy on trials.
Yeah, same thing here. We hardly ever do pre-op chemoradiation unless it's like a superior sulcus disease or something close to the chest wall, and for the surgeon feels like it would aid in their resection. Otherwise, if we do a trimodality approach, which we don't do very often here, and it's in part driven by the strength or lack of strength of your thoracic surgical oncologist, honestly.
Right.
And you can imagine, so we don't, so it tells you a little bit. But in general, we would do neoadjuvant systemic therapy. And I think, you're going to see a lot of immunotherapy up front from here on out in these scenarios, for sure.
Yeah, I agree. And we've had a trial here and seen some path CRs with the combination of chemo and immuno. And I think it's just going to make things more interesting with the data and the chemoradiation and then the surgical data and where this all kind of hits and how we compare the two. So we can go to the next slide. So this is my summary slide of where we've kind of gone, and I won't go spend too much time on the data, but we have these sort of landmark analyses that led to chemoradiation. We'll touch on 0617 in a bit. But I think really the last successful trial we had, or really the last defining trial, was RTOG 9410 that defined that concurrent chemoradiation standard. And so we had that going in, and we can go into the next slide. This is RTOG 9410, a good study to know, the classic study that taught us that concurrent chemoradiation is the standard. And they tried sequential was not as beneficial. This hyperfractionated radiation also not as beneficial. So we can go to the next slide. We can skip over this because I want to make sure we have time for the next studies, for the next speakers. So RTOG 0617, briefly for everybody that probably knows this already, a 2x2 randomized trial, 2x2 factorial. So they looked at whether there was a benefit of adding cetuximab. In summary, there was not. And then they looked at adding, seeing if there was a benefit of dose escalation. And unfortunately, or however you want to look at it, 60 gray was the standard and 74 gray was more harmful. Well, we can go to the next slide. I think 0617, I always joke that I wish I was an author on the study because it led to a number of other publications too. And I think we learned a lot from it. So, higher doses may not be the answer. In my opinion, I think Pacific kind of teaches us this is also a systemic disease, but hey, maybe with better systemic control, maybe we can start to dose paint, and we can get into that as a long discussion on how to maybe dose escalate, but do it safely and do it to active disease. And there's a number of studies trying to do that. My opinion, all IMRT should be standard for these patients. And every time I do a 3D plan for insurance purposes, it never is the same. But we learned about lung B20, and we knew that before, but this confirmed it. Heart, I think, was a very critical organ that we maybe didn't appreciate as much before, focusing on pneumonitis in the lung, but I think we're learning a lot in the last few years too, that heart matters. So I think we learned a lot. So it's, in my opinion, not just a horrible trial. I think it taught us a lot. So we can go to the next slide, and I'll try to wrap my part up because I think I'll spend some time on the next exciting topics. But I think we all know the Pacific trial, a randomized trial comparing chemoradiation followed by placebo with chemoradiation followed by durvalumab. And this, I think, has been obviously the big changer for our management of our unresectable stage 3 patients. So we can go to the next slide. And basically, they had two major publications and a number of them afterwards. But the first big one was on progression-free survival. And they showed a significant difference in PFS compared to placebo. You can go to the next slide. On subgroup analysis, it pretty much benefited all of these. Now we can have all these subgroups, and we can have a discussion at some point on our PD-L1 patients, EGFR patients, and whether they should be getting this or something else. But I think this was pretty clear that it helped a number of patients as far as the PD-L1 status. EGFR, the numbers were a bit smaller, so a little hard to say, but I know, and we can talk about that at the end here on what maybe we do for those patients or what we should be doing. We can go to the next slide. I always put this up. There was a small subgroup analysis. Initially, this trial was designed to randomize people 2 weeks after finishing chemoradiation. That was hard to do, and so they expanded it to 6 weeks. But I think it's important for people to know that. They did this subgroup analysis that at 2 weeks, people did better. And so if you believe in the friendship between radiation and immunotherapy, you would say that there's an immune response there. If you're a purist, statistician, you might say it's a selection bias, and people that are starting sooner just do better. But it's just something to be aware of. I always like to joke about it, but I'll go to the next slide. And so toxicity overall was the same, and I think that was important. Pneumonitis rates in general were very similar between the two groups, and I think that was one of the biggest concerns for everybody. And so we can go to the next slide. I'm sorry, I'm going fast here, but the subsequent study in New England Journal of Medicine was overall survival, and there was a significant overall survival. And again, another nice study that has had a number of publications, including the recent ASCO presentation that shows 5-year overall survival rates continue to be significantly better, which is great, and far higher than our rates of 20-30% that we had historically. can go to the next slide. I think we should be wrapping up. So time to death and distant metastases was reduced. Brain metastases, a big one, was also reduced. And so, this was, I think, a critical need in a stage where we're not just dealing with local disease, we're dealing with metastatic disease. And I think that's where a lot of the benefit came from. So we can go to the next, and we can actually, maybe we can skip through this and maybe go to the last slide. So these are just things that I put out there, and maybe we can touch on and then go on to the next exciting topic. But I think the role we have Pacific 2, we have a number of trials, even looking at hypofractionated radiation and immune checkpoint inhibitors, but how to give this concurrently with chemotherapy, without chemotherapy, I treat head and neck. And so, head and neck, we had a pretty big trial that showed there was no benefit of adding concurrent immunotherapy with chemo and potentially some toxicity. So we have to be a little careful, but I think that's where we're going. And there's some exciting research led by Dr. Higgins in small cell as well on the combination approach. Whether we should be going to higher doses of radiation, but maybe not so much the 0617 fashion, but using PET or other ways to really target areas and dose escalate, but do it safely. Should we be hypofractionating? And then I think, this one I wanted to point through, maybe ask Dr. Higgins and Dr. Iyengar, because this comes up a lot. City of Hope is a big EGFR positive population, and we do molecular testing on all patients. So we know our stage 3 patients that are EGFR positive. And after chemoradiation, we debate whether they should be getting maintenance Durva or maintenance Tagrisso. So I'm curious in your practice what you guys have been doing.
Well, we don't reflexively test stage 3 patients, so we don't have that data. I will say it's a complicated question because the patients, once they get chemoradiation, I don't know if they will be as responsive to the EGFR ALK inhibitors or not. My chairman Hawk Choi had an awesome study that was open through the entire NCTN network, which closed due to lack of accrual. But they were going to test everybody for EGFR and ALK, and then randomize them to neoadjuvant targeted therapy followed by chemoradiation. And in that way, that they should be responsive to this systemic therapy, to the targeted agent, versus chemoradiation. And so that was a beautiful study. It would have helped this patient population that you see a lot, but it closed early due to poor accrual. But we're going to see more studies for this population. And I think it's only after that should we really figure out how to sequence things.
Yeah, there's the LAURA trial that is sponsored by AstraZeneca that we have actually open at my institution for patients that are EGFR mutated. They get randomized to osimertinib or placebo. And so we are trying to put patients on that. If they decline that study, then we generally will give them durvalumab. But there's a new retrospective study in JTO from Heather Wakely's group at Stanford that shows that the EGFR mutated patients didn't benefit
Right.
from durvalumab. So, I think it's kind of an evolving area, and I'm sure there'll be more data.
Yeah, I agree. And we combined with our data. We gave some of our City of Hope patient data to them too at Stanford. So that's why we're a little biased, and I've noticed our medical oncologists actually going with Tagrisso a number of times. And I always bring it up as a discussion because I tend to agree that, it's without the data, I think we still would say Durva, but we here will do Tagrisso. So it's kind of an interesting transition. Well, great. I think that was all I had. So thank you. I will go on to the next case.
All right. Thanks very much, everybody. We can go to the next slide. So I'll start with the case. 65-year-old male with the right upper lobe mass, mediastinal adenopathy, good performance status, former smoker. We do staging imaging for a presumed malignancy, and it shows FDG-avid disease in the right upper lobe, multi-station N2 disease, and a left adrenal finding, which is concerning for metastases. We finished the staging with an MRI of the brain, which shows a 1.5 centimeter isolated mass, also consistent with metastasis. Biopsy of the nodal disease is positive for adeno-CA. So really the question is, what would be the disposition for this patient And as a radiation oncologist, would we be involved in any of the management? And since I have a lot of slides, I want you to think about that. Next slide. But I'll tell you what we would do here at UT Southwestern. We would do gamma knife for the brain mets, and that's how the radiation oncologist would get involved up front. And then, I'm biased, but we do first line therapy. And the reason that we start with first line therapy for these patients that look like they have oligometastatic disease is several reasons. Number one, we want to make sure that these patients don't have just a snapshot of oligometastatic disease, and that a month later they end up blossoming disease everywhere, and it really would have provided no role for local therapy up front. So we want to understand the biology of the disease more longitudinally. Second thing is it gives us a sense of whether the patients respond to the systemic therapy, and really and gives us an understanding of what we expect the disease course to be. So for this patient, they more likely would have gotten carbo-pem-pem. And then if they had stable disease, we would enroll them on LU002. As a reminder, that study randomizes patients who have oligometastatic disease with stable findings after 4 courses of systemic therapy to continuation of their systemic therapy alone, or local consolidative therapy to all sites of gross residual disease followed by maintenance systemic therapy. And really the idea of this trial is to answer one simple question: will adding radiation to a metastatic disease population, a unique one, improve survival? And that's what we want to know. More than likely, I would have done 45 and 15 to the intrathoracic disease, and 24 gray times 1 in an SBRT course to the left adrenal. And then these patients would go on to receive maintenance systemic therapy. And that's kind of what would have been our treatment paradigm. Let's say we didn't have the study open. At that stage, I think there are a lot of potential possibilities of how to go about doing it. And maybe the subsequent slides will help you understand why we chose this approach. Next slide, please. So, we all know that biology drives outcomes, and especially true for non-small cell lung cancer. And the more and more we identify targetable mutations, which are the most for any really solid tumor, we see all types of drug delivery systems. But why can't we assume and presume that limited versus widely metastatic disease also represents 2 biologic spectrums of this disease that could drive our treatment modalities? Next slide, please. And so, we know now that immunotherapy helps out patients with metastatic non-small cell lung cancer. Next slide. So the question then became, which really started in the 90s with Hellman and Wexelbaum's concept of oligometastatic disease. Can we squeeze local therapy into this treatment approach to improve patient survival outcomes? And why can we consider doing that? 1, better systemic therapies. 2, modern diagnostics that will help us guide local therapy approaches. Really all to figure out whether we can make this subset of non-small cell lung cancer patients potentially chronic, potentially have chronic disease or curable disease. I like to use the word chronic more than curable, but that was really the rationale. Next slide, please. And so what did we have some hope that this would be a reasonable approach? Yes. And part of it was the idea that a lot of patients do develop stable disease or responsive disease after first-line systemic therapy, up to 70% of patients. And then usually when they progress, which is a fact of life for these non-small cell lung cancer patients, even in the era of immunotherapy, they will progress most frequently in the original sites of gross disease. And so some elegant work out of the University of Colorado and elsewhere had us believe with their publications that being aggressive locally may actually be of benefit for patients with oligometastatic disease. Next slide. And so this is again the definition that Wexelbaum and Hellman came up with in the 1990s. Next slide. And so what is some other evidence that, we can that it would be beneficial to be aggressive? We really have to take our hats off to our surgical colleagues in metastatic sarcoma, metastatic colorectal cancer. Their aggressive approaches to surgical resection of pulmonary or hepatic metastases or even adrenal metastases really promoted an idea of improved overall survival in these unique patient populations. And so that's additional data that supported all of our field's hypotheses. Next slide. So again, ultimately metastases are not always widely disseminated. They do not always progress in multiple sites. And more than likely, they will progress in the original sites of Grove's disease. And so maybe there's a role for local therapy. Next slide. SBRT came in at the right time, right place. Great things about SBRT, as we all know, non-invasive. You don't have the surgical side effects, and the anatomical site's more amenable to SBRT from head to toe, which is what I tell most of my patients. Next slide. And so there was an aggressive approach with single institution studies as well as smaller prospective evaluations over the years to try to understand whether there was some signal to suggest a benefit to local therapies in the setting of oligometastatic disease. And across a multitude of cancers, that signal was pretty positive throughout the 2000s. Next slide. But really, it became necessary to do things more prospectively to gain some signal. And so I break down timing of local therapy and prospective trials into kind of three components, which I think are the relevant ones when you're thinking about local therapy for oligometastatic disease. One is consolidation, second is oligoprogression, and the third is abscopal effects. And we can go to the next slide and start talking about consolidation. So what is the traditional standard treatment paradigm for metastatic non-small cell lung cancer patients? It's usually been given in the era of cytotoxic chemotherapy, was giving them first-line systemic therapy. After about 4 to 6 courses, give them maintenance. In the era of immunotherapy, it is just basically continuing to give them immunotherapy. And so really the question, and then we would wait till progression, and then we would switch them to another line. We switch them to another line of systemic therapy. So really, the proposed shift in the paradigm was, in a prospectively generated manner, can we generate and develop data that supports our hypothesis that local therapy would actually be of benefit in the setting of consolidation, i.e., after the patients had received X amount of systemic therapy. Next slide. And so, there are a couple of very important studies for this. Of course, the study led by David Palma and Suresh Sanan was a randomized phase 2 study published in the Lancet in 2019 and JCO in 2020. They took all histologies of oligometastatic disease patients, randomized them to standard of care maintenance systemic therapy versus SBRT plus systemic therapy. And what they found was a very significant benefit in overall survival. What we need to remember is that of these 93 patients, about 18 had non-small cell lung cancer, and they were looking at an alpha beta of 0.20. This was not a definitive study. Their goal was to see if there was some signal to suggest a benefit. Next slide. And they did see a benefit. And then, of course, the MD Anderson study demonstrated a similar finding, but this was with just non-small cell lung cancer patients. And they found a similar improvement in PFS and OS, again, in a very similar range of improvement in terms of overall survival. It was actually a very significant improvement in overall survival. Next slide. And then we did a smaller study here at UT Southwestern that showed a similar improvement in progression-free survival at the setting of local therapy and consolidation. We haven't really talked about the overall survival yet. Some patients are still alive. So next slide. So, but really, I would argue that in the setting of oligometastatic disease, the non-small cell lung cancer field has really driven a lot of the nice prospective studies, randomized prospective studies, to give us a sense of whether these studies should be a go or no go for larger scale studies. Of course, the prostate field has done very well as well, and the breast studies are ongoing. But there are a number of studies that have looked at local therapies in the setting of single arm, in the setting of randomized phase 2s, and then ultimately have led to the next slide, please. Two, actually more than two large phase 3 randomized studies. LU002 is one of them, looking at local therapy in the setting of oligometastatic disease. Sarin out of the UK is doing the same thing. And hopefully they'll give us a true indication with an overall survival benefit in a study that is powered to look for an overall survival benefit. Next slide, please. So, the question becomes, and it would be very surprising to all of you that many areas and places are doing local therapy for oligometastatic disease, even though I would personally think that the data is not mature enough to support it. So why should we still kind of be careful about using local therapy in the metastatic setting in a more uniform way before the studies are finished, the largest randomized phase 3 studies are finished? And I'll tell you why. As I said about Sabre Comet, very few non-small cell lung cancer patients on that study. The signal the study was powered to achieve a signal, but not really a greater involvement of an understanding of whether there should be a benefit of local therapy. And so that is a caveat of that study. With the MD Anderson study, they included patients with targetable mutations. They included patients who had had surgery. So a little bit of a more heterogeneous patient population. And then more importantly, next slide, please. None of these studies were done in the era of immunotherapy. So what we really need to understand is whether immunotherapy is going to synergize with radiation therapy in promoting even better overall survival. We would expect that from Pacific, but we really should do it in a randomized way. And the question is radiation IO better than IO followed by radiation? Next slide. And that's more about biology. There's been some studies that suggest that there is a supportive signal for IO after local consolidative therapy, as well as IO followed by salvage local therapy. And so the jury is still out, I think, whether the immunotherapy is going to get so good that it's going to dilute the benefits of local therapy or not. And we'll just have to see by doing the studies. Next slide. Oligoprogression. Next slide. I think, there's really been very few prospective studies that have been published on oligoprogression. We had a single arm study that suggested that radiation in patients with non-small cell lung cancer who progressed through one or two lines of systemic therapy may be helpful. And let's just maybe go through the slides very quickly. Next slide, please. And it was basically patients who had progressed, then received radiation. Next slide. And what we found was that a PFS benefit was around 14 and a half months, overall survival 20 and a half months. And if you really think about it, for patients who have failed multiple systemic therapy lines, this was very good. But remember, this study was done prior to the era of immunotherapy. I bet with immunotherapy, these numbers would be far better. Next slide. It changed the patterns of failure, and you guys have access to these slides so you can take a look at it, but it may basically change the pattern of failure from local to distant. Next slide. And there are certainly important studies that are ongoing in Canada, at Memorial, and in Europe and England to see whether local therapy at the setting of oligoprogression will be helpful. Next slide. And then the abscopal effect, the glorious unicorn called the abscopal effect. Is it present in non-small cell lung cancer? Next slide. As we all know, abscopal effect is you treat one side of disease with radiation. It promotes an immune reaction that may facilitate immunotherapy-directed treatment of other sites of non-irradiated disease. I'm not going to get into the details. It's still an evolving field, and we'll see if it really matters or is important in the setting of non-small cell lung cancer. Next slide. So again, there are a few other reasons why I wouldn't rush to treat patients off study with local consolidative therapy. Next slide. We really don't know what is the ideal number of metastases to limit patients to, location of disease, volume size of disease, should patients with N1 versus N2 disease in the mediastinum be excluded? These are all questions that need to be answered. Next slide. Sequencing, I think, is the most important question. Should the patients be treated up front with consolidation, at oligoprogression, in an abscopal state, at multiple time points? Should we use tumor mutational burden? Should we use circulating tumor cells? Should we use functional imaging as the driver of the targeting of disease, as well as response to therapy, and when we should repeat local therapy? Still unknown questions. Next slide. And then ultimately, I think we need to put patients on our studies to answer these fundamental questions. Next slide. And then a few other things: progression-free survival versus overall survival versus objective response rate versus circulating tumor DNA. I don't know what the right endpoint is. NCI tells us it should be overall survival. Of course, that's the most ideal. But maybe there's some other early surrogates which would give us a sense of what would be the best endpoint. Next slide. So why is this all important? I think this is my last slide. This is all important because if you look at SBRT practice patterns in patients with oligometastatic disease, the number of patients who are receiving these types of treatments is skyrocketing to the point that by 2010 and later, nearly 100% of respondents said that they do use SBRT. Oh, there will be one more slide after this. Sorry about that. That they do use SBRT for oligometastatic disease. So clearly, they're doing this off study. And the question is, are we doing it? Are we really doing it to the benefit of our patients? And we need to ask, what is the appropriate endpoint and benefit that we want to achieve? Chronicity of disease, curability of disease, or so forth. So next slide, please. So in summary, I think SBRT in general for limited metastatic disease that's not leptomeningeal disease is safe, feasible, and potentially beneficial, but we really don't know the ideal timing and appropriate indication of local therapy for oligometastatic disease. And I think maybe in the next 3 to 4 years, some of these studies will read out, and I think we will have a much better sense of when and in which patients oligometastatic disease treatments would be most applicable. All right, so I will stop there and appreciate your attention.
All right, we will switch gears, and our last case is a case on limited stage small cell lung cancer. So I will go through this case, and then hopefully we'll have some time at the end for us all to answer questions and talk about all 3 of the topics. So this patient is a 51-year-old previously healthy female who presented actually as a patient who was about to get a knee replacement and had a chest x-ray for pre-op and was found to have a left upper lobe opacity. She was a former smoker. She had a diagnostic CT and eventually a PET CT that showed a 5.2 centimeter left upper lobe mass with hilar lymphadenopathy that were all FDG avid, no distant metastasis. Her brain MRI was negative. And then she had an EBUS with biopsy of the left upper lobe mass that showed small cell lung cancer. Immunostains were done and were positive for TTF1, some somnatophysin and chromogranin, which are your typical neuroendocrine markers that you would expect to be positive in small cell. TTF1 is not always positive in small cell, but most of the time is. Next slide. So we staged her as T3N1. The ISLC has recommended that our small cell lung cancer patients are staged with TNM staging. Our traditional ways of staging has been to just differentiate between extensive stage and limited stage, and that practice carries on in terms of clinical trial inclusion criteria and so forth. But I do think it's important to assign a T stage and an N stage. There's been some subset analyses of the CONVERT trial, for example, that shows that these can be prognostic. So she was T3N1, as I said, and she was treated on NRG Oncology LU005. We treated her 45 gray BID with cisplatin and etoposide 4 cycles. She was randomized to the control arm. So then she was assessed after she finished her 45 gray. She had a complete response in her chest to her chemoradiation, and she then received PCI 25 gray in 10 fractions with memantine. She would have been able to co-enroll on NRG-CC003, which is the trial of PCI standard or hippocampal avoidance PCI. Next slide. So I'm not going to take you all the way back to the Teresi trial because I know you guys all know that stone cold, but really the most modern day trial in small cell limited stage right now is the CONVERT trial. And this was published in 2017, presented at ASCO in 2016, and it compared radiation fractionation schedules once daily versus twice daily, 45 gray twice daily versus 66 gray once daily with platinum etoposide. I just want to point out the inclusion criteria for this trial included PS2 patients. Those patients classically have been excluded from the concurrent chemoradiation trials for stage 3 non-small cell lung cancer. So that's just a little bit of a nuance that those patients are included on these trials for limited stage small cell lung cancer. And what this trial shows was there was no significant difference in survival between these two fractionation regimens. The median overall survival was numerically better for the BID arm at 30 months. The daily arm was 25 months. From a toxicity standpoint, there was no difference in grade 3 and higher esophagitis. It was 19% in both arms, and no difference in high-grade pneumonitis, which was quite low, around 2 or 3%. So before this trial, we really didn't know which radiation scheme was optimal. There was really a lot of worry that 45 gray BID would produce a lot of esophagitis. We know now that it's essentially equivalent to 66 gray daily. I think the onset of the esophagitis is a little different with these fractionation regimens. You tend to see it more after treatment when you do BID, as opposed to with the daily radiation. It's sort of that last 2 weeks to week and a half of treatment where you have the most toxicity. The purists would interpret this trial as the standard of care of 45 gray BID should remain. Others interpret this trial as really you can do both fractionation arms. Next slide. And I just want to point out that this is the North American CONVERT study, RTOG 0538, and this is being presented at ASCO this year. So please, I just really took this data from the abstract that's on ASCO online, but I want to steer everybody towards the presentation that will be presented in the next few days. The schema for this trial started out as a 3-arm trial with the 3rd arm of a concomitant boost. That was dropped sort of early on in the trial design because it didn't really have any significant difference in terms of toxicity. And so we continued on with arms A and arms B. The daily radiation arm in this trial is 70 gray, so a little bit higher than the CONVERT study. And the recent ASCO abstract reports no significant differences in overall survival. The median overall survival is 30.5 months for the 70 gray arm versus 28.7 for the 45 gray BID arm. So we essentially have 2 large phase 3 well-designed clinical trials that show no significant difference in BID versus daily radiation. Here in 0538, the median survival is numerically higher for daily 70 gray. In CONVERT, median survival is just about the same as it is here, 30 months for 45 gray BID. So I think both fractionation arms can certainly be used for this patient population. I think at the end, I'll just ask Puneeth and Arya what they use, because I think it's good to hear different point of views in terms of which arms are favored. I will say it's certainly easier to give BID radiation if you're pushing up against a very large tumor and you're not able to meet your constraints. You can meet a lung V20 easier when you're delivering 45 gray versus 66 gray. And from a logistics standpoint, some people don't like to come twice a day, but some people it's easier if they're traveling 2 hours and they can stay in a hotel for 3 weeks. They want to get it done faster. So, you know, there's pluses and minuses to both approaches, but I think we have very good data now. 2 trials that really essentially confirm that survival is very similar between the 2 arms. Next slide. So in small cell lung cancer, it's really been sort of one of the forgotten diseases where we haven't had much improvement for many, many years until very recently. And this is in the extensive stage small cell lung cancer setting. We've had 2 positive trials that improved progression-free and overall survival when immunotherapy was added to first-line platinum and etoposide chemotherapy. And I just want to point this out to you residents in terms of your learning when you're studying different diseases. I think it's very important to learn about the standard of care in stage 4 metastatic disease, even if this isn't something that is necessarily tested on radiation oncology boards. You can learn a lot of insights, and if you're aware of what concepts are being tested in stage 4 disease, then you can really kind of understand what could be next in line for those stage 3 patients for a curative intent. And look at Puneet, for example, who really has made his career in oligometastatic stage 4 non-small cell lung cancer. So I think there's a lot of value in really knowing and understanding what the standards are for metastatic disease. Next slide. And so with the immunotherapy approvals for extensive stage small cell lung cancer, we've started to design new trials that incorporate immunotherapy into earlier curable stages of small cell lung cancer. And this is a table that we published in a review back in 2019 that showed the 3 trials that were testing immunotherapy in the limited stage of disease. There's actually now a few more that have launched. There's a study by Merck that is using pembrolizumab and a PARP inhibitor concurrent with chemoradiation. But I'll take you through some of these trial schemas. Next slide. So this is our trial that activated about 2 years ago. This is a phase 3 trial where patients are randomized to standard of care chemoradiation, and the fractionation can be given either 45 gray or 66 gray per the Convert trial. And atezolizumab is added concurrent with chemoradiation and continued on for 1 year in the experimental arm. The protocol treatment begins with the 2nd cycle of chemotherapy. We really did that from a practical point of view because many of these small cell lung cancer patients begin treatment as inpatients where they're not completely staged, they just get a cycle of chemotherapy. So we wanted to really allow for broad enrollment, and that's really helped the, I think, the number of patients we've been able to recruit to this study so far. The total accrual for our trial will be 506 patients. Right now we have around 280 patients enrolled. So hopefully we'll be meeting accrual maybe even in the next year or so. The primary endpoint is PFS for phase 2 and overall survival for phase 3. And PCI is recommended if patients have a complete or near complete response, assuming they have resolution of their high-grade toxicities. Next slide. So another trial testing immunotherapy is the Adriatic trial, and this is a study run by AstraZeneca where they are giving immunotherapy after concurrent chemoradiation and PCI. And it's actually a 3-arm trial where they can get durvalumab alone or durva plus tremi or placebo. This trial, I think, has nearly met accrual and should read out, I think, pretty soon, maybe even in early 2022. So that will be exciting to see the results of this study. Next slide. And there is also a European study that was a phase 2 study that was presented at ESMO this past year, the Stimuli trial. And here they gave Ipi-Nivo as consolidation treatment, sort of similar to the Adriatic trial. It actually closed early because of poor accrual, and the statistical endpoints were shuffled around a bit. Next slide. And here we have PFS and overall survival. The median time to discontinuation of immunotherapy was actually 1.7 months. So patients didn't tolerate this combination very well. Ipi-Nivo is toxic, and it didn't meet its endpoint in consolidative trials in the metastatic setting. Nonetheless, the overall survival, you do see some separation of the curves, so we'll have to follow this longer to see what it shows for overall survival. Next slide. Interestingly, if you look at the Stimuli trial, overall survival by radiation fractionation, it's possible that there could be an interaction between fractionation and efficacy. You see here the once daily versus the twice daily survival, and it's interesting, you see that hazard ratio for the twice daily is 0.41 for patients that are getting immunotherapy And that's, I think, interesting, thought-provoking, and we'll see how that pans out as longer follow-up is seen in this study. And also in LU005, I'll say in LU005, the fractionation is a stratified variable. Next slide. And then actually a year ago at ASCO, we had a study that was presented looking at dose escalation in limited stage small cell. And it's a phase 2 trial comparing 45 gray BID versus 60 gray BID. The primary endpoint was 2-year overall survival. It was positive. Interestingly, there was no difference in progression-free survival, which is a bit curious. But nonetheless, it's, I think, interesting to see that these dose escalation study in limited stage disease is positive. It's a phase 2 study. It certainly would require, validation in a phase 3 trial, but nonetheless, I think it is an interesting trial. Next slide. So I think in conclusion, in terms of radiation fractionation for limited stage disease, there's data to support 66 to 70 gray daily. There's good data to support 45 gray BID. My preference is to give 45 gray twice daily. It's unknown right now in the setting of immunotherapy if there's any interaction with radiation fractionation. That could be something that can be looked at in this generation of trials that's enrolling right now. And I just want to point out that there are a lot of research opportunities for small cell lung cancer. It's been sort of a forgotten disease, and there's great opportunities for trainees to come with novel ideas to really further advance the outcomes for these patients. And that is it. And now I have to ask Puneeth and Arya, what do you guys prefer for fractionation?
I'm a little bit indifferent. I think 45 is a nice regimen, as you said, because of the dosimetry. But a lot of my patients are in the charity hospital, and they just don't have the means to come twice a day. And so, I mean, that's a question, a resource question itself, the fact that they're not able to get the twice daily. Luckily, we have 2 regimens that seem similar in both efficacy and toxicity. So we're not affecting their outcomes any differently because they can't come twice a day. But that's generally our, I give equal option.
Yeah, I'm the same way. I give both as options. I more of my patients have gone with the daily. I think the twice a day, it's been hard for people to swallow, but.
We have a question for the patient under immunotherapy. Do you allow them to use or stop during SBRT? So I guess that's like for extensive stage small cell lung cancer patients that maybe are getting maintenance atezolizumab or something like that. So the thing about immunotherapy is it's not really like chemotherapy. It doesn't have a short half-life. You can't just stop it and say, oh, well, there's no chance of any, toxicity. The half-lives of these medications are very long, and you've sort of already started the pathways, and you can't turn them off by just stopping or holding one infusion dose. So generally, when I have patients on maintenance immunotherapy, I will just bring in SBRT, in between their Q3 week cycles. And I think there's mounting data that shows toxicity is certainly manageable with that approach.
Great.
Yeah, I agree. I'm curious too, like what if on an oligo progression, someone on Tagrisso, what do you guys do? Because I tended to hold it a couple days before, treat the lung, and then resume, especially if it's treating something like the oligo progression in a lung. But I'm curious what you guys do.
Yeah, that's what we do. We actually have a trial.
Yeah.
You guys are part of that study.
Right.
That study is, again, consolidation, but yeah, we hold 3 days before and then start up with 3 days after. And it's because osimertinib may itself have some inflammatory issues. And that's what some of the companies are trying to tease out around now.
Yeah, sometimes my medical oncologists don't like to stop the osimertinib because they worry about progression. So I've also, especially for bone mets, we will tend to keep the osimertinib on board for bone SBRT.
Yeah, absolutely.
All right, great. Before we wrap up, any additional comments from the panelists about any of the cases or?
Well, I'll just say real briefly, lung cancer is an awesome field. I think there are a lot of questions that are relevant for a radiation oncologist with respect to biology, with respect to the clinical side of things, with respect to physics side of things. And so, as I reiterate what Kristen said, there are many opportunities to do really outstanding stuff, to really help our patients. It's a very diverse patient population. There's non-smoking related non-small cell lung cancers that are, it seems to be increasing in numbers and frequency, and they affect very young patients. And so again, there are a lot of opportunities to make an impact.
Absolutely.
Definitely agree.
All right, well, thank you so much, everyone, for coming and attending. For the residents, please fill out the post survey. It'll help us improve these sessions. So this is the last one. We'll resume this series again next fall, but just wanted to put in a plug. We're starting ROVER for medical students in a few weeks, June 25th. So yep, great. So just if you have no interested med students that you want to recruit to radiation oncology, please have them check out our website and they can register and sign up for those sessions. So thank you again, everyone. Have a great weekend.
Thank you.